Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Dr. Rajiv Agarwal in Indianapolis, Indiana, with whom we would like to discuss the use of thiazide-like diuretics, particularly chlorthalidone, in patients with advanced chronic kidney disease, based upon his very recent CLICK study that was presented by Dr. Agarwal at this year's ASN meeting some weeks ago and pre-published in the New England Journal of Medicine again some weeks ago. So it's a privilege and an honor for us to have you tonight, Rajiv. Thanks for taking the time to be with us.
Thank you, Gunnar, and thank you, Anja and Marcus.
Dr. Agarwal is professor of medicine at the Indiana University School of Medicine, and he's one of the global leaders in clinical hypertension research. To name just a few of the major studies to which he contributed, he's co-author of Figaro, Fidelio, Innovate, Protect, and now surely of CLICK. My co-moderators tonight are Dr. Markus Säemann, president of the Austrian Society of Nephrology from Vienna, Austria, and Anja Scheuer, who will become a nephrologist in Frankfurt, Germany. My name is Gunnar Heine, again in Frankfurt, Germany.
My first question is, why did you initiate this study? What's the rationale behind it?
Thanks, Anja. That's an important question. We actually looked at the data from the last 30, 40 years. Chlorthalidone has been approved since the 1960 or so. And what we found was that there were lots of studies done, usually a dozen or so patients, and all of them tended to show some benefit in blood pressure lowering, weight loss, but none were adequately powered to test the hypothesis whether chlorthalidone is really lowering blood pressure. Also, all the guidelines said the same thing: stop thiazide-like diuretics when the eGFR is less than 30, and use loop diuretics when the eGFR is less than 30. So we just wanted to challenge the notion that is it really necessary to do that? And I think that was the genesis of the study.
Can you tell us a little bit about the trial design? I think 2,849 patients were actually screened, and then only 160 underwent randomization.
Yeah, so, a lot of different trials do things which are very different. We start at the very beginning. Anytime we look into the patient's chart to see if the person qualifies or does not qualify, we count that individual. And that's why you're seeing a few thousand people being screened. Now, of the people being screened, there are about 600 or so who agreed to come in for their first visit, and about 400 or so agreed to, they consented. And of those 400, 160 get randomized, because what we are doing is we are seeing truly if those patients are hypertensive. Of course, these are people who are hypertensive. They have to be on blood pressure medications, but we are confirming whether they have blood pressure that is elevated by 24-hour ambulatory blood pressure monitoring. Now, that's the gold standard. And we do that not just off the bat. We do it after just having them measure the blood pressure for 1 week. Then we have them measure their home blood pressure for another 2 weeks while they're taking placebo. And at the end of it, 3 weeks period, they wear an ambulatory blood pressure monitor. Their GFR has to be in stage 4 CKD range. Their blood pressure has to be elevated, and only then they get randomized. So you can see that we are being very careful in deciding who goes into the trial based on these inclusion-exclusion criteria.
And what were the main results of this study? Were there any considerable side effects?
Well, the primary endpoint in the study was the improvement in ambulatory blood pressure monitoring. And there's about a 0.5 millimeter reduction in systolic ambulatory blood pressure, and much more, about 11 millimeter reduction with chlorthalidone. So if you look at the differences in the change, it's about 10.5 millimeter systolic blood pressure reduction with chlorthalidone at the end of 12 weeks. Now realize that not all patients finished the trial. There were only 140 people out of 160 that completed the trial. So we had 20 people missing, right? That's 12.5% missing data. That is not a very large number, but we wanted to account for even these 20 people who don't have ambulatory blood pressure monitoring. So we do what is called a multiple imputation analysis. So statistically, you basically project what blood pressure could somebody have, and you create multiple data sets on the potential outcomes of the blood pressure had these people completed the study. It's an imputation. And these data that we're reporting are imputed analysis. If you look at the completer analysis, the effect is actually slightly larger. So it's about more like 11 millimeter systolic blood pressure reduction. But when you impute for the missing data, you penalize the data set for the missing information, we get slightly lower effect. Now you ask me about side effects. Well, the side effects are plenty. There is no free lunch here. So you get AKI, I shouldn't call it AKI. I would call it reversible change in serum creatinine. Why? Because AKI seems like you injured the kidney and something terrible happened to the kidney. These are hemodynamic effects of the drug. When you lower blood pressure, no matter how you lower it, the kidney function is going to be slightly lower. And that's what we saw, that, if you control blood pressure aggressively, the creatinine will go up. And it happens to be more in people who are on loop diuretics. So when you put loop diuretics on board and you then give chlorthalidone, the chances the creatinine will go up is much higher. So you have to be particularly cautious there. Now remember, the starting dose in this trial was only 12.5 milligram chlorthalidone, which is half a pill. Typically in America, we get dose of 25 or 50 milligrams of chlorthalidone. So we are just giving them 12.5 milligrams of chlorthalidone or matching placebo to these individuals. So that's a very low dose. And despite having this very low dose, you have reversible changes in creatinine. In the first 4 weeks, everybody got either 12.5 milligrams of chlorthalidone or matching placebo. And the reduction from baseline is about 10 millimeters mercury. Only after that, if the patients needed it, that means that blood pressure was still elevated, did we go up to 25? And a few patients needed as high as 50 milligrams. But, typically 12.5 milligrams once a day was what we used. There were other side effects: hypokalemia, hypomagnesemia, hyponatremia, hyperuricemia, hyperglycemia, everything that you know with thiazides, the side effects. They're basically, this trial is a textbook of all the side effects that can potentially happen, and they happen with the patients. So it requires very careful monitoring when you're using these drugs.
So why was this even questioned? Why did we think that thiazides might not work in patients with advanced CKD?
Well, people thought that, the drugs won't work because the thiazides will be ineffective in these people. They thought that in people who have less than 30 GFR, these drugs are very weak diuretics, they won't work. But clearly they work very well, or rather too well. If I had to do the trial again, I would start with 12.5 milligrams of chlorthalidone 3 times a week. I wouldn't even give it every day. 3 times a week is probably odds, especially if the people are on loop diuretics. So I have to be very cautious with this drug. This is a potent drug. This can hurt the patients if you're not cautious. So knowing what I know about this drug, I would use even less. And that's what I'm doing clinically. I'm not using 12.5 milligrams in everyone. If you're not on a loop diuretic, yes. But if you're on a loop diuretic, 12.5, 3 times a week is my starting dose. That's pretty reasonable.
Yeah, Rajiv, I'm really happy to have you with us here. I admire your works. They are often very innovative, counterintuitive, and have a direct clinical impact. So one of your studies prompted me to stop ACE inhibitors on dialysis completely. So, but regarding your work here now, I mean, you have convincingly shown that this chlorthalidone is really powerful. And it also suggests, it was not the primary endpoint, but that it's nephroprotective. So all in all, what would you suggest would be the overarching mechanism besides its blood pressuring effect? Is it a hemodynamic effect on the kidney? And could you consider it maybe in this very peculiar CKD4 population as a standard regimen in a lower dose for this population?
Very good question, Marcus. Thank you for your kind comments. These are people who have advanced kidney disease. They are sick people. And all of these patients, by study design, have to be on either ACE inhibitor, angiotensin receptor blocker, or a beta blocker. So we know from prior studies that it's a trial done in Oxford. It's called the ABCD. They came up with the ABCD principle. So if you have an ACE inhibitor or a beta blocker, they work better with a calcium channel blocker and a diuretic. If you add them together, they're synergistic. And that was the thought process. Not everybody who has CKD4 will qualify for an ACE inhibitor or angiotensin receptor blocker. For example, patients may have very little albuminuria. Patients might be hyperkalemic. So you want to maybe use a beta blocker in those individuals, not an ACE or ARB. So it's really required that everybody has to be on either ACE, ARB, or a beta blocker. And on top of that, we're using chlorthalidone. So we are almost synergizing the effect. I don't know if chlorthalidone will be as effective if it's not married to an ACE, ARB, or a beta blocker. So that's one caveat. The second is that proteinuria, albuminuria reduction was really, really remarkable, 50%, which is better than any of the SGLT2 inhibitors, finerenone. None of these drugs even come close. It's a huge reduction. It was a surprisingly robust amount of reduction. And when we follow these people long term, I was worried. I said, okay, you are saying that you have reversible changes in serum creatinine, right? How do you know you're not hurting these individuals? How do you know these are people who are not going on dialysis more or simply dying? So we looked at these individuals annually, called them every year. And the last patient was recruited in January, so we don't have complete follow-up on everyone. But for the people that we have a hazard ratio of outcome for going on dialysis or dying or having a sustained decline in eGFR of less than 10, whichever came first. The hazard ratio is 0.63, but the 95% confidence interval about that is 0.36 to 1.13. So there's a slight signal for harm, right? So 1.13 is obviously greater than 1. It may mean there's at most 13% excess risk of bad outcomes that can happen given the data that we have. But there's also a possibility there's a great amount of benefit. Knowing what we do about albuminuria and future risk, I think it's sort of going hand in hand, that the reduction in albuminuria is suggesting a long-term protection. Whether it is a blood pressure reduction or something else, is a very interesting question. So we called all these patients 2 weeks after we stopped chlorthalidone. At 12 weeks, everybody stops chlorthalidone. They come back after 2 weeks. At 14 weeks, we measure albuminuria again. And lo and behold, the albuminuria has not returned to baseline. It's still reduced compared to baseline, even though all the blood pressure effect is more or less gone. Well, half of the blood pressure effect is gone, but the albuminuria effect is persisting. Now, it's possible that the drug is very long-acting. and it has got a persistent effect, and the albuminuria reduction is all hemodynamic. But is it possible the drug is changing the intraglomerular pressure, reducing albuminuria, doing something special to the kidney? And this drug is so inexpensive. Everybody in the world has access to it. But what I want to say is that we have to be very cautious using this drug. Start with half dose of what we used in the trial with the loop diuretic user. You can use the 12.5 once a day in people who are not on loop diuretics, but be very careful and go slow, because otherwise you might say, oh, 25, the patient had acute kidney injury, I don't like this drug. You have to really respect this drug. It's almost as potent as a loop diuretic when it comes to blood pressure reduction.
Yeah, this was a mind-blowing effect, this lag effect, when you stopped and then you saw the anti-albuminuria effect, but nevertheless you saw that the GFR came back and still the albuminuria, anti-albuminuria effect was ongoing. So are there any experimental data or studies with single chlorthalidone without the RAS blockade?
So we invoke the tubulo-glomerular feedback as a potential mechanism. So TG feedback, they have been studied for a long time, especially by the San Diego group. Dr. Volker Wellon has studied it for a long time. And I cite his paper in the manuscript saying that, oh, could it be that this drug is having an effect on TG feedback? And therefore, when you stop the drug, the GFR comes back to where it should be, but you don't have the other effects.
Okay, this is very interesting. So, but it's also suggests maybe to start earlier, maybe in CKD stage 3 with chlorthalidone. Is there any kind of a visible plan to study this in patients with CKD?
So CKD3, we have data from SPRINT trial, right? SPRINT trial included CKD3. In fact, I was planning to study these patients 3B and 4 in the original study, but the reviewers told me, oh, you don't need to study 3B and 3A. We have data there. Stage 4 is where there is no data. 3A, 3B, we have data from SPRINT. You can look at the post hoc analyses and all they have published. So you have data there, but stage 4, there's absolutely very little data. So I don't have any doubt that it'll work in stage 3.
Okay. So my final question, so when a practical one, when I come as a stage 4 patient to you, would chlorthalidone be nowadays, today, be part of your armamentarium as a nephroprotective therapy?
I would say it's part of my armamentarium as antihypertensive therapy.
Okay.
No, if it is nephroprotective, I don't have substantial amount of data. All I can show you is surrogate information, improvement in UACR, and a hazard ratio for hard outcomes trending in the favor of chlorthalidone. But to answer that question, we really need a large trial in this population, right? You need a phase 3 trial. This is clearly a phase 2 trial. So I don't want to go and say, this is a great drug to protect the kidneys. I can say it's a great drug to protect the blood pressure. Because, that's all we studied here.
Yeah, because the fact that the question is now is coming finerenone, coming down to the GFR of 20 milliliters per minute. This will be possibly, at least in diabetic patients, part of our armamentarium. So we would, and possibly also SGLT2s coming down to 25, maybe 20 milliliters per minute. So we have then maybe 4 compounds to protect the patient.
Yes, you are right. But here there is we are not tethered by the cost of the medicine, right?
Yeah.
You don't have any issues with the cost of the medication. Anybody in the world can use it. In fact, there's some countries in the world don't have access to chlorthalidone. Like somebody reminded me, in Egypt, for example, there's no chlorthalidone. But most parts of the world will be able to afford it because a drug that has been there for 60 years and it works. And that's what is remarkable to me, is that after 60 years, we're discovering something which is, people were actually very hesitant to fund this trial because they said, you're really going to study a drug which is 60 years old? I said, yeah, why not? Let's find out if it works or not.
And it's similar to Spironolactone, so 50 years after there was the rain study. Yeah.
Absolutely. So I wrote an editorial on this, which is published in NDT. And, I compare the CLIC trial to the RALS trial.
Yeah.
And I say, just be very careful in using the drug, use it with a lot of respect. Just because it's almost free doesn't mean that you use it freely. Use it with a lot of responsibility.
Okay. So thank you, Rajiv.
Are you aware of anybody planning a phase 3 trial at the time being, or maybe in the future? Will we get any further data on the protective effects?
I think that trial is needed. I'm not aware of anyone. There is a comparative effectiveness study going on in the United States. It's a point of care randomization, very large study comparing hydrochlorothiazide to chlorthalidone in 15,000 plus patients. So that is an ongoing study in US. It's done in the VA system, and that's going on. But there's no placebo, and it's not limited to kidney disease patients. It's simply asking the question whether chlorthalidone is better than hydrochlorothiazide. Very different question.
So I would have 2 or 3 final questions. And again, we are all impressed by the data and we learned a lot. And I particularly learned that we should really start with low dosages, because I always tell my doctors here in Frankfurt, if you go for this kind of medication, this thyroid, then you should go with strong doses, but apparently this was wrong and we should really start with low dosage. I was also impressed by the low levels of sodium in the 24-hour urine. So apparently you did a great job in teaching your patients to avoid dietary salt intake. And if I remember right, mean sodium was around about 100 millimoles per day, which is much better than we do here, at least in Frankfurt.
Yeah, these patients are sicker. They have more advanced stage kidney disease. We gave them, a pamphlet that, hey, this is how you should eat. We didn't give them, a consult with a dietitian or anything like that. But they followed a low sodium diet. But, there are data from Friedrich Luft, in Berlin, in Charité. He has done studies which show that a single urine specimen may not be good enough to assess the dietary intake of sodium. In fact, what he has shown in the Mars project, these are the Russian cosmonaut project that he had collaborated, you need 1 week of data before you can say reliably what your dietary sodium intake is. So I would be cautious with these data, but we do find that people who have a lower level of sodium intake, they tend to have a better response to chlorthalidone, which would also make sense.
And those people who were randomized on chlorthalidone, were they able to reduce their intake of loop diuretics? Do you already have some data on this? Or did they just go on with their regular dosages of loop diuretics?
Well, we didn't change anything because, the trial design was that you hold everything else constant and you start them on a 12.5 milligram of chlorthalidone of matching placebo. So I don't know which group they would be in, right? And then you titrate up the dose based on blood pressure. So, you can see the titration of doses happen much more with placebo. With chlorthalidone, not much titration. So there's a figure in the supplement where we plot out, you have almost twice as much use of placebo in milligram per day compared to chlorthalidone, which would make sense. Chlorthalidone was working.
Did any of your patients already were on SGLT2 inhibitors? Or
One patient, one
patient, okay.
patient in all. One patient. I looked at, actually, Dr. Luft asked me this question, Frederick Luft. He asked me this question. So I went through all this 160 patients and I found one patient. These are stage 4 kidney disease, right? And we started the trial in 2016. So they won't be very eligible. And stage 4, there are very few people who would be eligible for SGLT2 inhibitors.
So actually, my last question would be about skin cancer. There's a lot of discussion, at least in parts of Europe, where the traditional HCT is no longer used or is at least associated with the development of skin cancer. So we are asked here in Germany to use other kinds of thiazide-like diuretics, just like chlorthalidone. Is this a discussion in the States, or do you not see these changes in the use of different thiazides and thiazide-like diuretics?
I was totally unaware of this information. So clearly in the United States, we are not discussing this.
Data from Denmark, and the people in Denmark have very strong data on adverse effects of their medication because they have national systems published some years ago by Anton Pottegard. And but unfortunately, the data are quite strong. But in Denmark, most people actually had the same diuretic medication. So mainly all people had HCT. So there are not really good data to compare to others.
I see.
Well, it has been again a privilege to meet you, and thanks so much for doing this study. And I'm not aware of any such study on loop diuretics, so I guess it's really the first larger study on any kind of diuretic treatment, hypertension effects in these people with advanced CKD. And it has been a pleasure to follow your presentation at the ASN, to read the paper, and surely also to meet you today. Have a nice holiday season. See you.
Thank you, Gunnar.
Goodbye.
Thanks, Marcus.